Pudendal neuralgia, also known as Alcock canal syndrome or pudendal nerve entrapment, is a rare but debilitating condition that causes chronic pain in the perineal region. This pain can feel like burning, squeezing, or even electrical shocks, and often severely impacts a person's quality of life. The pudendal nerve, which is responsible for sensation and function in the pelvic area, becomes compressed, leading to these symptoms. Although awareness of this condition has grown in recent years, diagnosis remains challenging due to its intimate location and the overlap with other pelvic disorders. In this video, we'll explore the latest advances in diagnosing and treating pudendal neuralgia, offering hope to those affected. The pudendal nerve originates from the sacral nerves and travels a complex path through the pelvis, curving around muscles and ligaments before branching out to serve the perineum, genitals, and anal sphincter. Its three main branches, the rectal nerve, the dorsal nerve of the clitoris or penis, and the perineal nerve, play crucial roles in urinary and fecal continence, as well as sexual function. Understanding this anatomy is essential for both diagnosis and treatment, as compression can occur at several points along the nerve's route. This complexity is one reason why pudendal neuralgia can be so difficult to pinpoint and manage effectively. Pudendal neuralgia can arise from a variety of causes. Common triggers include prolonged cycling or horseback riding, pelvic or orthopedic surgeries, nerve stretching during childbirth, and even anatomical anomalies in the sacroiliac joint. Professional activities that require long periods of sitting can also increase risk. The underlying mechanism is usually compression of the pudendal nerve, either between ligaments or within the pudendal canal. While the exact prevalence is uncertain, it is estimated to affect about 1 in 6,000 people in France, with a higher incidence in women between 50 and 70 years old. Recognizing these risk factors is key to early intervention and prevention. Diagnosing pudendal neuralgia is notoriously difficult. The symptoms often mimic other gynecological or urological conditions, and the intimate nature of the pain can make patients hesitant to seek help. The widely used Nance criteria provide a structured approach: pain in the pudendal nerve territory, worsened by sitting, not waking the patient from sleep, no objective sensory loss, and relief with a local anesthetic block. However, even with these criteria, misdiagnosis is common. Imaging and nerve blocks can help, but there's still a need for greater awareness among healthcare professionals to ensure timely and accurate diagnosis. Treating pudendal neuralgia typically follows a stepwise approach. First-line therapies include medications such as antiepileptics or antidepressants and muscle relaxants. If these are ineffective, local infiltrations with anesthetics and steroids are considered. Physiotherapy is recommended for patients with pelvic muscle hypertonia. For those who do not respond to conservative treatments, surgical options like nerve decompression may be explored. Each approach has its own benefits and limitations, and the choice often depends on the severity and duration of symptoms. The goal is always to reduce pain and restore quality of life. Recent systematic reviews have analyzed the effectiveness of various treatments for pudendal neuralgia. Surgery, particularly transgluteal decompression, appears to offer the best long-term results, with many patients experiencing significant and lasting pain relief. Infiltration therapies provide good short-term relief, but often require repeated sessions, as their effects tend to diminish over time. Radiofrequency treatments and electrical stimulation show promise, but more research is needed to confirm their long-term benefits. Osteopathic manipulation may help some patients, especially as a complementary therapy, but evidence is limited. Overall, the lack of standardized outcome measures makes it challenging to compare results across studies. Safety is a critical consideration in treating pudendal neuralgia. Fortunately, most interventions report low rates of serious complications. Surgery may occasionally lead to issues like hematoma or wound infection, but these are rare and usually manageable. Infiltration therapies can cause temporary side effects such as headaches or numbness, and in rare cases, transient nerve block or foot drop. Radiofrequency and electrical stimulation procedures are generally well tolerated, though long-term data are limited. Overall, the risk of severe adverse events is low, making these treatments viable options for many patients. Despite growing interest, research on pudendal neuralgia faces significant limitations. Most studies are small, with few randomized controlled trials and inconsistent outcome measures. Success is often defined differently across studies, making direct comparisons difficult. Follow-up periods also vary widely, and many therapies lack robust long-term data. This lack of standardization highlights the urgent need for larger, high-quality studies using uniform criteria. Only with better evidence can clinicians confidently recommend the most effective treatments and improve patient outcomes. Looking ahead, the field of pudendal neuralgia treatment is poised for progress. Standardizing diagnostic and outcome criteria will be crucial for advancing research and clinical care. Larger prospective studies are needed to clarify the long-term benefits and risks of each therapy. For now, surgery remains the most effective option for lasting relief, while less invasive treatments can offer temporary improvement or serve as adjuncts. Raising awareness among healthcare professionals and patients alike will help ensure earlier diagnosis and better management. With continued research and collaboration, there is hope for more effective and personalized care for those living with pudendal neuralgia.